Good afternoon, all the distinguished speakers, moderators, and all ladies and gentlemen. I'm Dr. Xu from National Taiwan University Hospital, and it is my great honor to be joined by in this session by Professor Eugene Koay from MD Anderson Cancer Center, Professor Stephen Chiun from Chinese University of Hong Kong. In fact, I'm not sure whether it is appropriate to call this session a debate, because we know that Asian physicians, Asian scholars are generally very humble and polite, and may not be very used to debate on resolve the issues in such a big audience. So I guess we may better consider this wrap-up session after hearing the excellent speech from all the previous speakers from different expert fields to assimilate all the data, rethink all the unresolved issue on the management of locally advanced intrahepatic cholangiocarcinoma. Okay. To prepare for this discussion, we have a pre-conference survey done by Taiwan investigators, including surgeons, radiologists, hepatologists, medical oncologists. We try to collect our experience and opinion before this meeting. And we hope that after the whole day's discussion, we may try to find out ways to approach the optimization of management for locally advanced intrahepatic cholangiocarcinoma. And now we think that we also want to take this opportunity to invite all of you to join this kind of survey. So could you now use your cell phone to log in to our meeting website? If you don't know how to log into the website, you can use the QR code scanner. The QR code is at the back of our page. You may scan the QR code, and then you can go to the meeting website. After log on into the meeting website, you may find the scientific program. There will be a pull-down menu, and in the scientific program, you will see there is a questionnaire here. Is that okay? And if your cell phone connection is good, then you will see this picture. There will be a total of There will be a total of 10 questions that we will try to ask to collect opinions from all of you. So anyone who wants to have some technical assistance, please raise your hand. Okay, so then let's move on. Okay. This pre-Congress survey is primarily organized by Dr. Chen Ming Huang from Taipei Veterans General Hospital. Thank you very much, Dr. Chen, for your effort before this meeting. So we finally collect the data from a total of 53 experts in Taiwan, medical oncologists, radiation oncologists, intervention radiologists, hepatologists, and surgeons. And we divide our pre-Congress survey into 6 big categories as shown here. And you can see that these 53 specialists come from different parts of Taiwan, a total of 12 medical centers or teaching hospitals. Okay, the first question we ask is like this. How many cholangiocarcinoma patients are diagnosed each year in your institute? We know that the biggest one is here, Chang'an Linkou branch, followed by Chang'an Kaohsiung branch. So these two hospitals, I believe, diagnosed more than 1/3 of total cholangiocarcinoma each year in Taiwan. And the other hospital, I think that the experience varied. And the distribution of cholangiocarcinoma according to anatomic location in Taiwan, not surprisingly, intrahepatic cholangiocarcinoma, almost half of our patients, followed by different other locations. So that's why our discussion today will focus on intrahepatic cholangiocarcinoma. Okay, when we asked our experts what kind of treatment guidelines your institution follow, all of them respond, okay, this is the NCCN guideline. This is most popular, most easy to use, and you can find pretty much everything in this guideline to choose from. So this flow diagram has been shown by Professor Chiun in her presentation regarding the treatment of locally advanced disease. I think that to define locally advanced disease, the first thing is to make sure whether the tumors are resectable or not. For resectable tumors, of course, primary treatment should be surgery. And for tumors confined to a liver, but not resectable by our expert surgeons, then we have to go to different options of liver-directed therapy or systemic approach. So this is the first question I would like to ask you to consider. Is what's your preferred definition of unresectable locally advanced intrahepatic cholangiocarcinoma? In fact, my answer is I will ask my surgeon. But just consider you yourself is a surgical expert, and your patient asks you to consider whether his or her tumor is resectable or not. You may choose more than one answer, so please vote. 15 seconds. Okay, now we have 23 votes. So anyone who needs some technical help to connect? Okay. Now it's 39 surgical experts. Great. Okay. Let's see the result. Oh, the font is a little bit too small. But we can see that most surgical specialists consider the insufficient future liver function remnant is the most important factor to consider resectability or not. I think this really reflects how important Professor Ye's presentation about portal vein embolization, how to increase the function remnant to improve resectability. So Professor Ye is still here? Okay, so then we will go to the second one. This is the PreConference survey from our experts. Again, you can see that insufficient function reserve here is considered important by many of our surgeons. But there is another thing that we consider important is whether the intrahepatic vasculature was invaded by the tumor. So this is another major limitation for surgical resectability. So Professor Shen, would you want to comment on this point? Okay. This one?
Yeah, because we evaluate the sensitivity from the MRI, we check the tumor related to second range. It means we cannot reconstruct the tumor very well, or we cannot clear cut the tumor. So I choose the third answer.
Okay, thank you. So this is a very important technical concern for resectability. Question number 2. We have heard a lot of discussion about neoadjuvant therapy. We know that there's no optimal approach. Probably everyone has his or her preference. But if it were you to choose for your patients from different neoadjuvant approach, liver-directed therapy, or systemic approach, so what will you choose among all of this? So please vote again. Ablation therapy, transarterial chemoembolization, internal radiation therapy, external radiation therapy, arterial infusional chemotherapy, systemic therapy, or you will not choose any neoadjuvant approaches. Please vote. Okay? Okay, let's see the results. So probably I will ask Professor Viro's opinion first, because you're from Thailand and you have seen the world's most difficult diseases. So what did you choose?
Personally, I'm a medical oncologist, so I choose a systemic therapy.
Yes, I know. I'm a medical oncologist too. So you choose only systemic therapy, or other choices you may also consider?
Yeah, in our experience, we prefer the systemic therapy because most of our patient kind of, it's sort of, even you try some other local therapy, then it's still unresectable in general.
Mm-hmm.
But however, there are certain patients that we give the radiation therapy, but we use less TACE or the SIRS spheres, because those are, I think it's biologically, it's a different disease, unlike the hepatocellular carcinoma.
Mm-hmm. Okay. We know that the Professor Chiun will choose the external beam radiation, right? So you didn't? Okay. Okay. So probably we may ask another radiation oncologist. Will Professor Koay give your opinion?
Yeah, I actually chose number 6 also, because that's actually the only one that I think we have good evidence, at least some data to suggest that it actually downstages patients. We've only seen anecdotal evidence that radiation or any other of the others can actually downstage patients. So I think that right now the only evidence-based, even though it's very weak, is systemic therapy.
Okay, thank you. So other options, I think the opinions are quite evenly distributed among these approaches. May I ask Professor Runchuan Li's opinion regarding chemoembolization or internal radiation?
We have some experience, I cannot say evidence. We have experience that using Y90 can shrink the tumor and let the tumor get away from the major structures and have the possibility to get resection. Another one is after radiotherapy, after Y90, the contralateral lobe will hypertrophy and get more future liver remnant. So it's possible for Y90 to increase the possibility of resection.
So you just mentioned one very interesting point in that the Y90, the internal radiation therapy, may not only serve a means to downstage the tumor per se, but it may also serve to have some effect, like Professor Ye mentioned, the portal vein embolization to increase the future liver remnant. So that will be a very interesting observation to see in future clinical studies. Okay, next. Okay, now going to technically unresectable diseases. I asked our respondents what kind of liver-directed therapy they use in their institution, and I asked them to make the total number should sum up to 100%. So you can see here the majority of liver-directed therapy are external beam radiation, TACE, and followed by other approaches. And you can see that for individual liver-directed therapy here, ablation therapy, TACE, internal radiation, external beam radiation, the distribution varied widely among different institutions, and the experience mostly limited to several or tens of cases per year. I think that depends on a lot of different factors, including institutional or physician's preference, as well as specific patient's conditions. So with that, I think I will hand on the podium to our next moderator, Professor Chiun, to follow discussion about other liver-directed therapy. Thank you, Stephen.
Okay. Professor Eugene, thank you very much. So we will move to the next questions, which mainly about some of the local ablation treatment for patients with locally advanced ICC. So this is the first questions. Under what circumstance will you use ablative therapy like RFA or PET for the locally advanced intrahepatic cholangiocarcinoma? These are the 6 choices. Certainly you have a choice of never. You don't use any local ablations if you don't believe. But let's have a vote first. Some is about the tumor number. Some is about the tumor size. Some is about the anatomical position. And also about the hepatic reserve. So suppose total 30 should be the reasonable number, right? So okay. We do have some intention to vote, of course, as voted. So suppose we have already 30. Let's see the results. Okay, I think it's quite. We do have most numbers opting about the tumor size, which is smaller than 3 centimeters. And also another criteria is the tumor number, less than 3. And also the anatomical positions. And also some may choose the inedible for surgery and inadequate. And some do choose the never. Probably, may I know who vote for never? I just want to know, because we don't have very high level evidence. Anyone who only use chemo and never use ablative therapy? Okay, sorry. Okay, then maybe ask. Do we have some interventional radiologists who give comment on what modality or what criteria you opt for the locally advanced tumor? Yes, Bruno.
Hi.
Thank you.
Yeah, I chose 1 to 5 because I think those patients, number one, they need to be ineligible for surgery to consider ablation. As you mentioned, we don't have enough evidence to do a head-to-head comparison and advocate as ablation as the primary treatment for those patients. And 2, 3, and 4, they are technical factors, lesion size, number of lesions, and it needs to be on a safe location. So I think they need to be taken into consideration. And obviously, number 5, the liver function, it's essential. You might, it's a minimally invasive procedure, but it's not an inconsequential procedure by any means. You can have major complications with ablation. So you need to take in consideration the patient has adequate liver function. So tumor size, number of tumors, adequate liver function, and in a favorable location.
Yeah. Thank you. Can I ask a follow-up question? I can see one of the considerations of the tumor burden in terms of tumor size and the tumor number. Do you have a cutoff, say, of the tumor burden, that beyond that, you definitely you won't use any local ablation, while within this limit, you will seriously consider?
Yeah, not for cholangiocarcinoma, of course, there is no evidence on that, but on colorectal cancer, the consensus among the different interventional radiologists is up to 5 lesions measuring up to 3 centimeters each one of them. I think more important than the number of lesions is how aggressive the tumor biology is. If you're, ablating a patient today for 2 lesions and 1 month later he developed 3 more lesions, I don't think it's effective. So we need to show some disease stability before embarking on a local regional therapy. But in general, 3 to 5 lesions at most.
Okay,
yeah.
Thank you. Do we have other definitions or consideration? Maybe we know we have a previous voting before, right? Let's show the result to our audience. Right, for this question, we should have some previous, I think, 下一张是 yes, I think it's quite compatible what have been voted in the, sorry, could you go back to the one slide? Sorry about that. What have been also voted by the audience, still the tumor size, number, and some anatomical locations. Okay, we have at least some consensus. Let's move to the next question. Yeah, 下一张是 the question is, how often will you consider ablative therapy curative in the circumstances mentioned above? So probably I think the key concept is, will you consider these ablative therapy as a curative, like equivalent to surgery? Probably I think surgeon will vote for 0, but let's see. Whether higher than 50%, 25 to 50, or 10 to 25, or lower than 10%. Yes, let's have a vote. $20, 20, maybe wait for a bit more. Maybe we can have to see the result of the voting. Yes, this is also what I expect. Probably, I think quite a lot, 60% of the audience consider that even with effective local ablations, it's still not considered as a curative. Probably you have seen recurrences or distant metastasis afterwards. We do see some different opinions. Do we have some audience who consider, or you have experience of seeing long-term control or cure the population after the local ablations? Yes, please. Yes.
In my department, we choose patient just the tumor below 3 centimeters to local radio frequency ablation. So for this kind of patient, I think it's a curative and ablation. So do you have experiences, or you have some case series showing that you can achieve long-term disease-free control? Yes.
3 centimeters.
But yes, below 3 centimeters.
Any other different thoughts or opinions?
Can I make a comment?
Yes,
Yeah,
please.
sorry. I think, first thing is comparing ablation with surgery. It is somewhat difficult because when you do surgery on those patients, in a good number of times you do a major appendectomy, and by that there is a, inferior reducing the size of the liver that you can actually, can recur. So my point is, when you do ablation, you're doing something very local, and there is more real estate on the liver of the patient to recur. That's one point. The other point is the definition of curative procedure. I don't think we'll be able to cure a systemic disease with a local therapy, but one potential advantage of ablation is we can give this on-demand approach. So the patient comes, has one lesion today, you ablate it, and he or she might develop another lesion 6 months down the road, and you can ablate that patient again. So I don't think it's a curative treatment, but you can apply the treatment in different time points and try to, as much as you can, control his macroscopic disease with that.
Thank you. Maybe we move to the next questions. So how often will you consider, under what circumstance, this time we move from the local ablations to the regional treatment, the TACE, either the conventional TACE or the adaptase for locally advanced ICC. You can choose more than one answer. Under what circumstance will you use the TACE treatment? There's 8 choices for you. Normal hepatic vasculature, perfusion, hypervascularity, status of the portal vein, some parameters reflective of the liver function, performance status, or never. You never use the TACE. Miss away. This is probably more fun to the audience, so the pick-up rate is high. Okay, let's see the results. I think hypervascularity is a point, and also the portal vein status, patent, and also the 6, I think, is normal hepatic function, and others considerations also maybe few also consider. So it's mainly about the vascularity of the tumor, the portal vein status, and the liver function. Maybe I go back to Professor Lee. What's your experience? Well, how will you choose the patient for TACE? Is it similar to HCC, or it's a bit different?
For the embolization for ICC or intrahepatic cholangiocarcinoma, I think it's not so effective as HCC, of course. But for the 0.3, the hypervascular target tumor, we always think the cholangiocarcinoma is hypovascular. Actually, intrahepatic cholangio is quite hypervascular, especially we can demonstrate it on this CT during hepatic arteriography. So local regional therapy through intraarterial route, it probably have some effect of HCC, I think. But for the portal vein invasion, probably the adaptase will not doing very good. Also, the liver function is hard to consider, but we don't have to have normal liver function. We have a good, adequate liver function. Probably we can do the local regional embolization. Thank you.
Thank you. Do we have other thoughts? Then we can see, I think we have a pre-conference result quoting. Can we show the result? Is there any difference from the, yes, no, this ablation. I think you do have a TACE pre-conference result. Yes, these are the pre-conference survey. I think it's largely similar. We do have people voting for the hypervascularity, portal vein, some major ascites, maybe people are concerned about the liver failure, and also I think the hepatic function. So largely similar with what our audience are voting. So I think we will move to the last question before I move on to our other panel members for leading. I think the last question is, can you show us the next questions? Okay, still going back to the vascularity. How often will you consider the locally advanced ICC hypervascular based on imaging findings? I think this word hypervascular, we take a reference to the HCC, that degree of the hypervascularity. So from your experience, how often will you encounter those hypervascular, the ICC? You have 4 choices. Oh. We wait for a bit more. 20. Maybe the Wi-Fi is a bit slow. Maybe give a few more seconds. Maybe we can still show the result. Yes, please just show the result. Yeah, 19. 好，谢谢. Oh, interesting. We do have quite a diversified answer. I think higher proportion, 60% people will consider 10 to 25, while we have around 1/3 over 50. Of course, this may vary, depends on your definition of hypervascularity, but maybe do we have some oncologist or IR colleague or surgeon who can share with your experience how hypervascular is the ICC? Dr. Furuse, I can see you, my friend. Yes, please share experience.
I'm an oncologist, but very curious answers. My impression, not so many patients have the vascularity for ICC, so I want to vote less than 10%, but my iPhone doesn't work.
Okay.
So I want to know how about the definition of hypervascularity for ICC different from HCC?
Yeah, definitely less vascular than HCC, right? Yeah. Any other experience? Maybe as a panel, I can also share experience. We have been leading one clinical trial on the Y90 followed by GEM-CIS chemotherapy, and because we basically use the definition of or our experience with HCC in those angiogram and looking at the hypervascularity TN ratio, our experience is ICC is definitely not as hypervascular as the HCC. So the TN ratio is usually also quite low as compared to the HCC. So, but it doesn't mean that it's not hypervascular, and definitely IRs can still have some role in the procedure. Yep. Do we have any other comments or experience sharing on these questions? If no, I will move to our Eugene for next part. Thank you.
Thanks. Thanks, Stephen. So I will finish up with the last couple of questions. So can we move on to the one about CERT? So question number 5 was about the rationale for the selective internal radiation therapy instead of TACE. So I think that these are things that have been discussed extensively by our speakers today, especially Dr. Odisio, who very nicely summarized the evidence. So we'll wait to hear from the audience and see how many people use these based on any one of these answers. 14. So we're just, the only thing waiting between dinner and moving on to the next session is you guys answering the questions. Okay, so that got people motivated here. So we'll see what the results are. Okay. So it looks like there's three answers: personal preference, improved therapeutic effects, as well as taste failure leading the charge here. So I guess by a show of hands, which institutions are using Y90? Which of your institutions are using Y90 for cholangiocarcinoma currently? Does it include pretty much everybody? For those of you who are not, do you want to speak to why?
There's not a scrap of evidence that it works.
I think that's
why
fair.
we don't use it.
Yeah.
If there was evidence, we'd use it.
And to those of you who do use it, what would you reply? Milind?
Well, there's single institution data, plenty of it, from Northwestern and several other centers, but there's no randomized study.
Yeah, I think the data are limited, and I think that it's a matter of patient selection. There's been quite a bit of discussion about hypervascularity for the disease. I think one other point to consider is the blood supply for the disease. With HCC, it's primarily an arterial blood supply, whereas with cholangiocarcinoma, it may have a dual blood supply, both from the arterial as well as the venous systems. And so even if you have hypervascularity, where you might expect a good delivery of your intraarterial therapy, the venous blood supply may still supply the cancer cells and keep them viable even after an arterial embolization with SIRT. So maybe let's move on to the next question. Oh, and yeah, thank you. So the previous questionnaire also seemed to reflect this, except for the personal preference. It seemed that most of the respondents, looked at, reduced post-rate embolization syndrome, as well as minimization of disruptive side effects as their reason for using SIRT instead of TACE. Okay, so we'll move on to questions about external beam radiation now. So again, for full disclosure, I'm a radiation oncologist, so I think that I'm one of two in the room. So under what circumstance will you use external beam radiation therapy for locally advanced intrahepatic cholangiocarcinoma? So there's 6 different answers here, but well, 7, I suppose, never being an option as well. So please go ahead and answer online if you don't mind. Okay. So we have we just need a drum roll to. Okay, so unresectable, medically inoperable is the #1 answer here. Oligometastasis in distant organs is also a close, a second close answer. But there's a variety of others. So R2 resections, R1 resections, there are a number of you who have answered that. Close margins was also a common answer. I'm curious, who was the one who never uses radiation? Even for locally advanced disease? So what?
I presume you mean external beam rather than SBRT.
Correct, yeah.
Said SBRT as voted yes.
I see. So you guys use 3 to 6 fraction SBRT for locally advanced disease?
I'm a surgeon. I just send them to something.
Right. Well, you don't personally, but your institution does. I see. Okay, very, very fair. I mean, SBRT is a form of external beam, so that's we meant to include that. Yes. So you would have answered one of the other ones. Okay, fair enough. Okay. Yes, and then for unresectable, medically inoperable, that's our standard at MD Anderson. We often start off with some induction chemotherapy, try to use that to select patients who may benefit for local regional therapies like external beam radiation, sometimes Y90 or other Dabiri TACE, for example. But more often than not, we'll be referring the patients for high dose radiation, as was very nicely summarized today by the speakers. We published some data on proton radiation therapy, 15 fraction radiation therapy, as well as dose escalation, and those results have convinced us that this doesn't necessarily cure patients, but it does prolong survival in these patients by improving local control of the disease. And as Dr. Adisio nicely summarized, many of these patients with locally advanced disease die of tumor-related liver failure, whether by biliary complications or vascular complications, just by local tumor growth. So this is where by achieving better local control, whether by surgery or external beam radiation, we've seen improved results. So that's the reason why I answered number one as the primary reason to use external beam. Okay, so I think we just have two more questions, and those are both related to radiation. These were the pre-survey or the pre-conference results from the survey here in Taiwan. So again, very reflective of what the audience here has responded. Okay, so this was a question that I was curious about. These last two questions were ones that I wrote. So I was curious, for each of your institutions, what duration of chemotherapy, if you use external beam radiation or SBRT for locally advanced disease, what duration of chemotherapy would you give prior to treating with external beam radiation? Again, either a 15, 25 fraction course or SBRT. Would it be 1 to 4 months, 4 to 6 months, more than 6 months, or no induction chemotherapy at all prior to referring to a patient to radiation oncology? Go ahead. All right, so it looks like most people would do a pretty standard course of 4 to 6 months of chemotherapy. No one answered more than 6 months. And then there are a few who answered no induction chemotherapy. So there are actually institutions where you'll just refer patients directly to radiation oncology if they have locally advanced unresectable disease. Is that correct? Does anybody practice that way? Can you just raise your hands and maybe answer to what your rationale for that particular practice pattern is?
Yep. Well, I think if the patient, him or herself choose not to use systemic therapy, then we will refer this patient to our radiation oncology colleagues. Otherwise, we will still discuss with them about whether to use chemotherapy up front.
I see. Yeah. Melinda and I have shared a couple of patients in the past where they're medically inoperable. They otherwise would have been technically resectable, and we gave high-dose radiation, and some of them are disease-free and have never touched chemotherapy. So there have been some very select cases like that also at our institution. But more often than not, for locally advanced disease at least, we usually do induction chemotherapy. Okay. All right, so very last question, and we can move on to the networking session. So, this will be a more technical question for the radiation oncologists in the room. So we're probably expecting less than 10 results here, but we'll see. So what dose of radiation do your patients receive for intrahepatic cholangiocarcinoma? If you don't know, then that's okay. But generally speaking, would they receive a 5-week course, more conventional fractionation of 50 to 60 gray? Would they give a hypofractionated course, as was discussed earlier? This could be 67.5 gray and 15 fractions, or even 100 gray and 25 fractions. As the MD Anderson group has published, a BED of around 100 gray is considered to be ablative for this disease now. Individual SBRT is also option here, and then there may be other fractionations that your institutions may use. So just curious to see what kind of radiation treatments your patients are receiving. Okay, 14 is pretty good. All right, and climbing. So it looks like SBRT is the most common. I think I and one other person are the only people to use hypofractionation here, or maybe that's another MD Anderson person. Okay, but there are a good number who still use conventional fractionation for this disease. The reason for this question is that we've published on how dose escalation can lead to better local control. So higher doses, beyond 50 to 60 gray, were associated with better local control as well as prolonged survival in our series with locally advanced disease. And this was nicely summarized earlier by one of our speakers, Dr. Song. So, I think that one of the points here is that by achieving better local control, you can potentially improve survival for this disease, and that requires higher doses, certainly better technology. But this is one where we've tried to help to show that by using these advanced technologies, you can escalate the radiation dose safely and help to lead to better survival outcomes for our patients. So with that, I think that ends our session. I don't know if Dr. Xu do you want to have some closing remarks?
Well, I think that together we have made a miracle to end our sessions ahead of time, right? Okay, thank you, Eugene. Thank you, Stephen, for your efforts. And now I think we should invite Professor Li Zhongchen to give the formal closing remarks. Thank you.